has been placed in listen-only mode. If you have any questions during the presentation, please submit them via the Q&A portion of the WebEx, and we will address them as time allows. Additionally, we thank you for your participation in a brief poll that will be issued during the last 5 minutes of today's webinar. With that, I will hand it over to Dr. Ray.
Hi, all. Welcome back. And Allison, can you advance the slide, please? So, of course, as always, you will get information about how to request CME for attending this webinar subsequent to the webinar. And we have a jam-packed webinar for you today. We welcome back Dr. Daskalakis, who is going to give us an overview on the COVID zones and the Cluster Action Initiative and what that means for all of us in New York City. And we have Dr. Han and Dr. Leila Wong, who will, by popular demand, answer a lot of your questions about the different kinds of testing and their indications. Can you advance the slide, please? And again, I will, of course, start with the overview of the recent epidemiology, and we'll get started. So where we are now, global cases continue to increase. India still has the highest number of daily cases, but India's numbers are declining, whereas we're seeing a second surge in European countries, as well as new cases in the Americas, including the United States. Certain New York City areas, as you will hear about later in the presentation, are seeing a concerning increase in cases. However, overall, across the city, the test positivity remains less than 2%, and you'll see some more details about the U.S. and New York as we continue the presentation. 3 areas in New York City have been designated by New York State as requiring restrictions on school attendance, businesses, and gatherings. These are cluster zones, and again, you'll hear about that later in the presentation. And can you advance the slide, please? So, as usual, we have a map here of recent case counts over the past week by different countries. You can see that the United States remains red, indicating that it has a high number of average daily cases. You can also see, as we discussed, some areas in Europe and India, although India is contributing, has been contributing and has been a major contributor over the last several weeks to the global case, new global case count. You can see that it has fallen from the dark red to an orange color, indicating it is less of a hotspot, less of a new hotspot. And of course, cumulatively, we are almost at 39 million cases worldwide with over 1 million deaths. And can you advance the slide, please? So this is a spotlight on the United States, where you can see the course of new cases. These are a 7-day average of daily cases. And as you can see on the top graph, we had a peak in March and April. Of course, we remember in March and April, we weren't testing as widely as we are now. And so this peak is actually probably higher than what we've measured. July and August, we saw another peak, and you can see that the case numbers are creeping up again as we approach the end of October. Similarly, with deaths, you can see that there was a very large peak of deaths following the first peak. There was a second peak of deaths a couple weeks following the peak of cases in July and August, but deaths remain stable for now on a nationwide level. We've got over 8 million cases cumulatively in the United States and over 217,000 deaths. And can you advance the slide, please? Similar to the map that we looked at worldwide, this is a map of new cases in the past week in the United States. As you can see, New York largely remains on the lower end of the spectrum of cases, and we can see a lot of new cases popping up in the Midwest. And can you advance the slide, please? So now we return to New York City, where, again, we see a curve that's similar to what we've been seeing the last couple of weeks, with a very large peak in March and April, and then a long stable period. you can see a very the small beginnings of an uptick in the number of cases as we get to October. Hospitalizations mirror cases, and then, of course, deaths seem to follow the trend of cases and hospitalizations, but occur a couple of weeks after diagnosis. And our cumulative count, we are almost 247,000 cases in New York City, with over 58,000 hospitalizations, 19,264 confirmed deaths, and 4,651 probable deaths. And can you advance the slide, please? This is a graph that we showed you and explained, Dr. Thompson explained last week. But this is a small graph showing the trends of recent New York City cases and deaths. The first curve is data shown for the 4 weeks ending at the end of September, and then we have updated this for the 4 weeks ending October 10th. And you can see that there is a small uptick in weekly cases, and weekly deaths, as reported, have decreased. But this is probably reflecting a stable number of deaths. And can you advance the slide, please? Now we have recent cases by New York City zip code, which again, you'll hear a little bit about in Dr. Daskalakis' presentation. So you can see that in southern Brooklyn, the number of cases has increased in a way that is not really proportional to the increases that we see in the rest of the city. You can also see areas around Williamsburg and Queens where we are seeing these increases in cases. And then that's in terms of the case rate per population. So that is tagged to an area of higher population that's accounting for that. And if you look at the pure case count number, we are seeing some similar patterns. And then we are seeing an uptick in cases in areas like the Rockaways as well. And we're seeing some large circles up in the Bronx. And can you advance the slide, please? So we have a couple of quick scientific updates for you. And the first of these is a topic that we've heard a lot about in the news lately, which is this ongoing conversation about whether SARS-CoV-2 has airborne transmission, whether it is airborne transmission or through the air. And I think the primary message that we've had about SARS-CoV-2 from the beginning is still true, and that is that the principal mode of transmission of COVID-19 is via infectious respiratory droplets. These are produced, we think of them during coughing and sneezing, but also heavy breathing, speaking sometimes, and singing. And there's a somewhat artificial separation in a spectrum of droplet sizes. So when you think about respiratory droplets, those are larger droplets. Sometimes you can even see these droplets, and these don't travel through the air very well. They fall out of the air within seconds to minutes. The smaller droplets, smaller particles, can remain suspended for many minutes to hours, and these are the small droplets that we're concerned about traveling on air currents. Of course, as these droplets are dispersed from larger droplets to smaller droplets, the concentration decreases because the volume of air they're diluted in increases. And can you advance the slide, please? So we've looked at the concentration of the droplets and the size of the droplets differ between respiratory droplet transmission and airborne transmission. The other thing that we have to think about is that airborne transmission is not equally efficient for all different microbes. Again, using the epidemiology of COVID-19, we've we know, because we've seen through transmission dynamics, that close contact is the major way that this virus is transmitted, and that airborne transmission is not the primary driver. However, as we learn more and more about the virus, we have learned that airborne transmission can occur in certain circumstances. What some of the concerning circumstances that we're hearing about on the news are enclosed spaces in which an infectious person is exposed to susceptible people, or prolonged exposure to respiratory particles that are really expelled forcefully, such as shouting, singing, and exercising situations. And of course, we all know about aerosol-generating medical procedures, where instrumentation is often done to the throat or nasopharynx area. So the existing interventions that are recommended do appear to be sufficient to prevent transmission of COVID-19 by airborne transmission. And of course, these are physical distancing, face coverings, and this is widespread use of face coverings, of course, hand hygiene, surface cleaning and disinfection, and of course, ventilation, and really avoiding crowding indoors. And can you advance the slide, please? The second scientific update we have for you also comes from the CDC, and this is a review of our knowledge thus far to update the, it seems, ever-growing list of underlying medical conditions that can put adults at increased risk of severe illness if they contract COVID-19. And of course, this list is a living document. If you remember at the beginning of the pandemic, we had a small list of symptoms, and that has, of course, grown as we have learned more and more. And can you advance the slide, please? So I encourage you to review this list of conditions based on the evidence that they can increase the severity of COVID-19 in an individual. But as a reminder, the recording of this presentation and the slides from the presentation will be available shortly after it is over. You'll notice on the slide that there are some conditions that we're familiar with. Cancer is something that we have been concerned about from the very beginning of the pandemic. Type 2 diabetes mellitus, again, has always been on this list. We discussed in a much earlier webinar obesity and the contribution of obesity, or the association of obesity with severe COVID disease. You also see things like smoking, COPD, heart conditions, sickle cell disease, and solid organ transplantation. But again, if you want more information on that, please review the slides, or there's a link at the bottom of the slide to the full brief. And can you advance the slide, please? Finally, for our updates, we'll return to another topic we've discussed many times on this webinar, which is multisystem inflammatory syndrome in children, which is a complication that occurs subsequent to infection by subsequent to infection with SARS-CoV-2 in children and adolescents. It often occurs a couple of weeks after the infection has resolved. We're of course still learning much about this condition, but this publication we're describing is actually reviews a similar syndrome, but occurring in adults. And this talks about what we're calling MIS-A as opposed to MIS-C in the UK and England from March to August. And you can see a lot of similarities with the symptom profile that we saw in MIS-C, including a predominance. Everyone of the 16 patients studied did have evidence of cardiac effects, which is a topic we discussed on the last webinar. Fever and GI symptoms are also very, very common. Interesting to note that none had severe respiratory illness, but they did have evidence of pulmonary injury on chest imaging. And can you advance the slide, please? So, of course, we don't know the pathophysiology of MIS. either MIS-C or MIS-A. In this study, we noted that some patients did have a negative PCR, but a positive antibody test, which of course means that they may not have presented for testing. And it does suggest that MIS-A and MIS-C, based on the production of antibodies and the timing of the illness in those that did have an initial PCR test, that it is a post-infectious process. MIS-A, just like MIS-C, can be quite severe and require hospitalization, but the vast majority survive. And then, as we have also seen in MIS-C, there is a disproportionate incidence in racial and ethnic minority groups in both countries. Of course, further research is needed to understand the pathogenesis, the management, and the long-term effects of this condition. And can you advance the slide, please? Finally, we want to remind everyone that the election is coming up, and some of you have already voted. Please vote safely during COVID-19. We have a link on our website, which we can post into the chat, on how to vote safely during COVID-19. Among the suggestions, including requesting an absentee ballot, especially if you have one of those conditions that we talked about that predisposes you to a more severe course of COVID-19 if you are infected. And the deadline to request an absentee ballot is October 27th. Voting early. And of course, as always, follow the core 4. That means stay home if you're sick, wear a face covering, practice physical distancing, and of course, good hand hygiene. And can you advance the slide, please? And now I want to introduce Dr. Daskalakis, who is going to talk to you about increases in community transmission in New York City neighborhoods.
Thank you very much. Can you hear me?
Yes, we can.
Great, thank you. So I will continue on with this presentation and talk about some areas in New York City where we are seeing some concerning increases in community transmission. I'll start by saying that we are taking very sort of thorough action that includes monitoring the epidemiology locally, as well as implementing New York State's Cluster Action Initiative, which includes restrictions in 3 zones that have been referred to as red, orange, and yellow. I will share those with you shortly. Additionally, we have done a lot of focus on our testing and take care interventions in those areas, as well as ongoing media and outreach that is both regionally, culturally, and linguistically accessible. So the list of areas of concern in Brooklyn and Queens are on the slide. I will not go over them in detail, but just to show you that there are some areas in Brooklyn, and I will show you the map briefly, that are over 7%, actually one approaching 8%, but many that are sort of looming in this sort of area between 3 and 6% positivity. I'll remind you that citywide percent positivity is just a little bit over 1% right now. Also, we're seeing similar areas of concern in central Queens. Again, you can see that here it's looming around, so the highest zip codes are looming around 4%, and then Far Rockaway, 1 zip code is involved, and that is approaching 6% positivity. Based on these observations, New York State designated zones that reflect areas of increased transmission, and then subsequent to those areas, surrounding areas that are in effect a buffer zone around them. So red zones are in effect the driver of the rest of the geography. They're the areas that have the most disease activity. Around that is an orange zone, which is really about a 5-block to quarter-mile radius around the red zone. And then around that is a yellow zone, which is a larger geographic buffer around these 2 other zones. So it's really important that folks know in what zone they live and work so they know their potential risk of exposure and restrictions that may apply to them. I'll remind everyone that though these are really important zones to think about, that everyone in New York should be adhering to the core 4 and should really try their best to do what we did in the past, which is to use these non-pharmacologic interventions to try to prevent ongoing transmission. And again, the goal being to flatten the curve or even prevent the curve from starting to increase citywide. New York City has a way for you to look up addresses, and this is both for work, home, and school. You can enter the address or place or intersection in New York City, and it will tell you exactly which zone, red, yellow, or red, orange, or yellow. And so this is what the COVID-19 Zone Finder website looks like. Again, nyc.gov/COVID zone is how you find it. And you can see the red, orange, yellow areas in southern Brooklyn, in Queens, as well as in Far Rockaway. Sorry. Sorry about that. I think I'm controlling it, so it's okay. I'll forward, just making sure we're not dueling. So again, this is the zone finder, and you can see the zones. We can now zoom in more, so you can see red, orange, yellow. Again, the geographies are a little bit hard to discern, so really important that folks are actually using that COVID zone website to identify where they are on this map. Now, there are differential restrictions based on the zone. So again, the area with the red zone where the percent positivity is highest has more severe restrictions. So for the red zone, schools, actually for the red and orange zones, I'm not sure. Yeah, for the red and orange zones, schools are closed. Yellow zone schools are open, but there are testing requirements for those schools. In terms of businesses, in the red and orange zone, only essential businesses can remain open, and there's a definition of essential business available at the website on the bottom of the slide. In the yellow zone, all businesses are open. In terms of food service establishments, red zone, only takeout and delivery is allowed. In the orange zone, outdoor dining is allowed with a maximum of 4 people per table, and the yellow zone allows both indoor and outdoor dining with a maximum of 4 people per table. In terms of houses of worship, 25% capacity up to a maximum of 25 people allowed in the red zone. Orange zone is 33% with a similar cap of 25 people, and then yellow zone is 50% maximum capacity. In terms of gatherings, both indoor and outdoor, all essential gatherings are prohibited in the red zone. Orange zone gatherings of maximum 10 people are allowed, and yellow zone maximum of 25. Important to remember that there are potential fines associated for people who are found either promoting or organizing gatherings that break these rules. So in terms of our response, we have been deploying resources to significant clusters in both parts of the city, on all 3 parts. We're taking a hyperlocal approach to targeted zip codes in the Bronx, Brooklyn, and Queens, and sort of this is now expanded as we are addressing these zones. And it's really important to try to take action now to reverse these trends. So we really need your help and your voice as providers to help change the trajectory and remind people that COVID is not over, and that it is not impossible that we will experience upticks that could potentially lead to more severe citywide interventions. So this is our chance to try to address these as we're experiencing local upticks. I will now move on to some updates in testing guidance. And so one of the important comments I'll make before I go into this is that individuals who are in these red, orange, yellow zones should be encouraged to quickly get tested. And so it's really important that the testing intervention continue in these sites. Now, in general, we've also released a health alert number 38 that talks about testing, specifically about very clear guidance. So the first and most important statement is that if someone has symptoms, or as a recent exposure to someone with known COVID-19, or again, works or lives in an area with increased COVID-19 activity, there is no schedule. That person should go for a diagnostic test. And by diagnostic test, I mean a nucleic acid amplification or antigen-based test. I do not mean serology. There are also certain special circumstances where testing should be conducted. That includes people returning from a restricted state as designated by New York State, people who attended an indoor gathering of more than 50 people, and also it's a good idea for people who plan to visit someone with an increased risk for COVID-19 to get tested 2 or 3 days before they depart. Additionally, beyond the diagnostic testing, we think it's really important that we give some guidance around screening. So screening people who don't have symptoms or a known exposure is really designed to prevent asymptomatic and pre-symptomatic transmission. A positive test results in referral to our test and trace core, which means that we provide resources for individuals to stay either isolated or quarantined depending on their circumstance. The current guidance is to offer monthly screening using nucleic acid tests, except with certain exceptions, to the following groups every month or as deemed appropriate for their setting and local epidemiology. So this includes residents and staff of long-term care facilities, healthcare personnel. One reminder, is that staff of these long-term care facilities must be tested weekly per New York State guidance or guidelines. Healthcare personnel should be offered tests monthly, and workers with frequent contact with large numbers of persons like child care staff, teachers, and first responders should also consider testing every month. Screening every 1 to 3 months can occur for others. And again, this is guidance, not guidelines, so they're recommendations. So specifically people attending events where physical distancing is not possible and workers who interact with others. It's important to remember that the exact interval in this range should be based on shared decision-making with the patient. So I think you'll find in your practice, at least I found in mine, that people ask how often they should get tested. And so this is just to give you a little bit of a guardrail around that for your own thinking. If you have someone who doesn't really understand their risk or it's unclear or unknown, it's reasonable to go to the sort of baseline of monthly testing. Again, this is all about shared decision-making between patient and provider. Another really important piece of guidance that is just echoing what the CDC has released is that we should be judicious about who we retest for COVID-19. So retesting individuals who test positive for COVID-19 and remain asymptomatic after recovery is not recommended within 90 days of initial symptom onset. If they were tested while they were asymptomatic, it's the date of the first positive test that you start that countdown. Now, there could be people who develop new COVID symptoms, and it may be worthwhile doing a reevaluation using testing. We recommend in that scenario to consider consulting with an infectious disease expert. If you want to read more about this guidance, the CDC goes into a bit more detail around the 90-day recommendation. So, what can you do to help, given that we're seeing some evidence of resurgence? So the first is to encourage testing. Ask patients where they live and work. Use COVID Zone website to see if they're in the zone with increased COVID-19. Ask them what they do for a living so you can help them figure out how often they should get tested, if it's appropriate. And also ask them about travel, since there are quarantine ramifications depending on where they go. Additionally, promptly report COVID-19 point-of-care test results with all required information that includes school and employment via eCLARS, the Electronic Clinical Lab Reporting System. This is critical for us to accurately monitor incidence and % positivity, since these point-of-care tests don't go into our electronic system without someone entering them. Also important because the positive test results in contact tracing. Also, if you have people who are at risk for COVID, check in with them. Make sure they're getting tested. If they are positive, make sure that you're giving them ways to think about seeking a higher level of care if necessary, and continue to explore and explain the importance of the core 4. That's covering face, physical distancing, washing hands, and again, people who are sick staying home to prevent forward transmission of the virus. And here they are in a graphic representation, the core four. And I will add the fifth is get tested. So with increasing capability of testing in New York City, with turnaround times that are back to around 2 days on average, we do encourage New Yorkers to seek testing and to consider both diagnostic and screening strategies in terms of how they approach testing. And with that, I will hand the baton over to our colleagues from PHL, who will give an overview of SARS-CoV-2 testing. Thank you.
Thank you. Can everyone hear me?
Yes, we can hear you.
Great. So my name's Megan, and I'm here with Mindy, and we're going to give you just a brief overview of the SARS-CoV-2 testing that's available and discuss the pros and cons of these different techniques. Can you advance the slide, please? But before we jump into these tests themselves, I want to briefly discuss the current authorization of different COVID tests. So the FDA has issued what's called an emergency use authorization, or EUAs, for many different coronavirus tests, categories of which we're going to discuss later during this talk. And these authorizations allow unapproved medical products to be used in this emergency situation. And the authorizations are granted because there's no other adequate approved or available alternative. And please keep in mind that even though these EUAs are not the same as FDA approval, we are able to use them in a number of different situations during the pandemic. Can you advance the slide, please? So looking at the tests themselves, we can see they fall into two distinct categories. First, we have tests that are looking for the virus itself to determine if a person is currently infected. These tests are falling under the category of virology, which I'm showing on the left here. And the two main types of virology tests are RNA tests, which are nucleic acid amplification tests, or antigen tests. RNA tests are also subdivided into two categories, and those are PCR and isothermal amplification. The second group of tests are serology tests, which are based on blood products. And these tests are looking for antibodies that are produced in response to coronavirus infection. These antibody tests can be divided into both clinical laboratory tests and point-of-care tests. Advance the slide, please. Now, before we get into the nitty-gritty of specific tests, I'd like to discuss two terms that come up a lot in reference to COVID testing. First is sensitivity. When we talk about how sensitive a test is, we're discussing how much material needs to be present for the test to detect that it's there. So, for example, if we're looking at this simulated sample vial on the left, if you have a test that can detect just one of our SARS-CoV-2 particles, the test has high sensitivity. If the test can only detect the virus, if many particles are present, then that test has low sensitivity. The other term we consider a lot is specificity, which is looking at whether your test can distinguish your desired target from other similar targets. So in this diagram on the right, if your test is only detecting SARS-CoV-2, it has high specificity. But if your test detects SARS-CoV-2 and coronaviruses A and B, it has lower sensitivity. And in general, the best tests have high sensitivity and specificity. Advance the slide, please.
Okay, this is Mindy Leadalong, and I'm going to step in to discuss the different types of viral tests that we have subdivided into two categories. The first is nucleic acid amplification test, or NAA test. And so there are many different tests in here. In fact, the last time I looked on the FDA website, there were 186 nucleic acid amplification tests that were authorized for use under the EUA. They're called amplification tests because the viral RNA is enzymatically replicated. And so what that means is that you have an increased signal and then thus a higher sensitivity. So PCR is probably the best known and often considered the gold standard, but isothermal amplification testing is also another subset. within this category, and it also has very good sensitivity. So there are both laboratory-based and point-of-care options for both PCR and isothermal testing. So on the right is one example of a point-of-care isothermal test. This is the Abbott ID Now COVID-19 test, and this uses cartridges that can be performed at the point of care. The one on the left is the Cepheid Gene Expert Infinity, and these also use cartridges, but it also has a robotic arm. So these tests can be relatively expensive. Many of them use these single-use specialty cartridges and have several different processing steps. And additionally, they use enzymes as well, so that also increases the cost. One concern, though, within the microbiology community is that because these tests are so sensitive, they can pick up viral RNA for many weeks after symptoms have waned in some individuals. So in the next slide, I'll talk about antigen detection tests. And these are tests that detect a viral protein. There are fewer options in this category. There are 6 tests that have EUA authorization. As of now, all of these can be used in patient care settings, though that will change in the future. But they're all easy to use, relatively easy to use, and can be completed in about 15 minutes. And the results are either read using an instrument like the one on the left, that is the Sophia from Quidel, or they can be read visually, and one example of that is the Abbott Binax Now, which is a lateral flow card. So they're not very complex, so the cost is a lot lower compared to the nucleic acid amplification test. But since there is no signal amplification step, they have lower sensitivity than the NAA test. So on the next slide, I wanted to provide additional context and put this in the perspective of sensitivity. So generally, you can think of rapid tests as having lower sensitivity and lab tests having higher sensitivity. And so these are sort of ranked from left to right, from starting with lower sensitivity on the left and higher sensitivity on the right. However, sensitivity should not be considered just strictly in terms of the test category. The specimen type is also very important. So for most of these tests, there are several approved specimen types. And the way that you should think about it is that the more virus that can be picked up, the better. So nasal pharyngeal swabs or NP swabs, those specimens have the highest sensitivity. And nasal swabs will have much lower sensitivity. And this is something that we've seen here at the laboratory with the Abbott ID Now test. So for example, when that is used in conjunction with NP swabs, the sensitivity is close to the laboratory-based NAA test. And so obviously some considerations are things like PPE availability and patient age. And those are all factors that should be considered for what type of specimen is used. Okay, on the next slide, I just want to go over diagnostic versus screening tests. So diagnostic testing is intended for individuals with symptoms of known exposure. And as was mentioned earlier, NAA tests or antigen tests can be used. So even with lower sensitivity tests, the virus can be detected because the viral load will be higher. But for screening, and this is testing intended for individuals who do not have symptoms and without any known exposure. For the most part, the more sensitive NAA tests should be used. So this graph will help you visualize this. So this is a graph that was from an article, a recent article from the New England Journal of Medicine. So an NAA test can detect lower viral levels, and that would be that green section on the graph, so in this pre-infectious positive by PCR area. And so this is why it's beneficial to use an NAA test. However, antigen testing can be considered for congregate settings if testing can occur more frequently. So This is also represented in the graph with the dashed horizontal line with the low analytic sensitivity. If testing is performed frequently enough, it is possible to capture the infectious phase even with a lower sensitivity antigen test. And so I alluded to this earlier, but here's another interesting thing to point out in this particular graph. The NAA test can be so sensitive that they may detect viral RNA even when this individual is in the post-infectious phase, or what's called the post-infectious phase here, and that is that purple bar right above the x-axis. Okay, I'm going to hand this back over to Megan Hahn, and she will talk about serology.
Thank you. Could you advance the slide, please? So our second type of testing category falls in the realm of serology, and that's where we're using blood products to look for antibodies within samples. And these tests fall within two main categories, clinical laboratory tests and point-of-care tests. However, these tests really operate on the same kind of concept. So what you have is you have either in your clinical laboratory test on the left, you have your wells in this 96-well plate that are coated with antigen, or you have in your point-of-care test a lateral flow cartridge that is also coated with antigen on the inside. And what happens is you'll apply your sample, generally your serum, to these plates or the cartridge, and your antibodies, if present, will bind to the antigens in the test. And these tests allow us to determine if a patient likely had prior COVID-19 infection. However, it does not tell us anything about a possible current infection. And I'm going to show a graph on the next slide, which is going to allow us to look at that a little more closely. So if we go ahead and look at this graph, as you can see, on the x-axis, we have time, and on the y-axis, we have our analyte level of SARS-CoV-2 analytes. And as you can see, we have serology detection unlikely as we have our antigen level increasing and our RNA level increasing. And it's really only later in the infection period that serology detection becomes possible, and you start seeing this increase in IgG and IgM antibodies. And also, as you can see, at later periods in time, you're also detecting fewer antibodies. So you really have this period for serology where serology detection is likely. So you can have people who are infected, and if you give them a serology test, it might not test positive, and you can have people who were infected a long time previously and may not test positive, which is a drawback for these kind of tests. And additionally, one other consideration when giving serology tests is to really reinforce with the patient that if they get a positive result, that does not mean that they are immune to the virus. It is still possible to contract the virus a second time, as we're seeing in some patients, on top of the fact that these tests have a somewhat high rate of false positive detection due to a lower sensitivity rate. And you can advance the slide, please. And that's all we've got for you today. And this is just a very brief overview of all of these tests. There are many tests out there from many different manufacturers, and which specific manufacturer and which specific test you're using also needs to be closely looked at and researched prior to implementation. Yeah, thank you.
All right, so as usual, we have some additional resources on COVID-19 that you can look at your leisure after the slides and the video are posted. As a reminder, they'll be posted on the provider section of our page, nyc.gov/health/coronavirus. And if you scroll to the bottom of the page, there's a whole section for webinars. And I think we have one more slide on CME. Yeah, so please follow the instructions here and look at the link that we have posted to collect your continuous medical education. I always forget to do this until it's due, so you know, be prepared and get it early. Now we have a few questions based on what you've put into the chat. I'll start with a hard one, which is for Dr. Hahn and maybe Dr. Daskalakis. But we had a question on, so for the concerning zones, so for the red zones, for screening tests, do we need to get a confirmatory diagnostic test?
Sorry, so the question is for a screening test, which can either be a point of care rapid test or a laboratory-based test, do you need a confirmatory test? So since we you know, mainly recommend using nucleic acid-based testing, laboratory-based is great. So I think if you're sending a lab-based test, that is adequate. And I'll ask PHL colleagues if they would like to sort of say comment further. But I think if you are doing point of care tests, the emergency use authorizations often require that a negative test is reflexed to a lab test. I'm not sure if folks from PHL, if you agree with that.
That's right. So the tests that are point of care antigen tests are intended to be used within a specific time frame after the onset of symptoms. If you use it off-label and test individuals that are asymptomatic, you can also send that for reflex testing, send negative specimens for reflex testing.
All right.
I was going to say, this is Mary. I think the most important takeaway in this kind of scenario is you really need to look at the clinical picture. So if you have a known exposure or any kind of concerning symptoms that could be consistent with an infection and you're using an antigen or point of care based test, then you should reflex to confirm with a lab-based NAAT test. Thanks.
All right, great. And can we just talk in general about the turnaround times for different test results and how that might impact a decision about which test to choose?
So we can speak on the turnaround times here at PHL. I can't really speak for the other commercial laboratories, though. The laboratory-based tests, we have a 24-hour turnaround time for those, and that is for both. That is for the NAA test. So I know that depending on where you go, you will get a range on that, and I'm not familiar with what those numbers are, though. And then also I should point out that these point of care tests, these usually take about 15 minutes. So it obviously depends on the sort of testing scenario. It's possible to do, for example, point of care testing and then reflex the negative to the laboratory as well. That is another option.
Comment, citywide turnaround time is around 2 days, sort of across the board at all labs. Also, the 75th percentile of the sort of folks with the highest turnaround times has really crashed down. So it's actually approximating around 3 days. So overall, turnaround times in New York City are great. And so most commercial and academic labs are included in that number, as well as our public health labs. So definitely a different place than we were several weeks ago.
Great, thanks everyone. And we have a question here on that was from earlier in the presentation, but it's really about how neighborhood level data reflects. Can you just comment, and I think this is for you, Dr. Daskalakis, on how neighborhood level data and looking at data on the neighborhood rather than the city level can tell us about impacts of socioeconomic status and race, and then the follow-up to that is really why we use percent positivity and what that tells us about differential access to care.
Hi, I'm sorry, I was speaking on mute. So first, I think that in general, neighborhood-based views are actually important in understanding transmission, as well as sort of testing dynamics. So I think I would refer you all to our website that actually has a lot of information about testing rates as well as testing in general. So I think that the answer is that, that neighborhood-based views are very much influenced by socioeconomics and really longstanding racial inequities. So I think that that's question one. Question two about percent positivity. So I think it's pretty, it's one of the metrics that we use frequently for a couple of reasons. It tends to be more stable in terms of day-to-day testing trends, and even on average. Like you see less of variation depending on how you cut the data than you would for testing numbers, which sometimes jump all around. So for instance, like on Saturday, our testing numbers are very low in the city because people don't get tested. And so it's one of the indicators that we have used really since the beginning of this, really when we first published indicators in April. And it is also one that the state uses on their early metrics. So I think no single indicator is enough to sort of make large policy decisions, but in terms of demonstrating where disease activity is, these are very handy. Additionally, we use a very well-developed statistical strategy that does use percent positivity as well as case rate together to identify areas of concern in terms of disease transmission. And so they tend to correlate really well. And percent positivity, like I said, is one that's used both nationally as well as by the state and us. Thanks.
Great, thank you. We have one, I think, for our PHL colleagues, and we're asking about the sensitivity, and I assume also about the specificity, but really the sensitivity of a provider-observed anterior nares swab versus a formal nasopharyngeal swab.
Hi, so when looking at the different specimen types and the specificity and sensitivity, generally the NP swabs are going to be the most sensitive, yield the most sensitive and specific results. We've actually done some testing here at the THL that has shown that the NP swabs are the most specific and sensitive overall compared to the NARS, regular nasal, and OP swabs as well.
Yeah, and this is Mindy. I'll just chime in to say the way to think about it is that the more viral particles that could potentially be picked up, the better. And so you will get better sampling with an NP swab compared to a NARS swab.
Great, thank you. And we have another testing question, which is we have a request for a general discussion of pool testing as a strategy and the pros and cons of it.
This is Mindy Leibowang again. Yeah, I can comment on this. So we, for pooling, there is a very rigorous validation process that laboratories have to go through to demonstrate the change in sensitivity and specificity. So that results from pooling specimens. And so because you are diluting the specimens by combining other specimens into one pool, there will be an inherent reduction in sensitivity. But from what we've seen it is a very small reduction, and there really hasn't been a change in the positivity rate comparing pooled and unpooled specimens.
Great, thank you. And just a reminder to everyone, you should be seeing a quick poll. So as we continue answering questions for the next 5 minutes, we really encourage you to fill out that poll. The information that you say you want to hear about is, we work really hard to provide that content in future webinars. And then let us come up with another question here. We have a bunch. We had a question about the case fatality rate. And so the question was really, and I think this is for you, Dr. Daskalakis, that we have case rates and we have death rates. So have we learned anything about the case fatality rate? What's the problem with just dividing one of those numbers by the other on a given day?
Sorry, I don't think I heard the whole question. Could you repeat?
Oh, sure. So I think this is a question that I've heard from a lot of different providers, but I think this is coming from the fact that there's a perception that the virus has become less fatal. And so there's a question about, given that we have case numbers every day and we've got death numbers every day, can you just divide them and get a case fatality rate?
No, so I think that's dangerous to do, mainly because I think that we are sort of at this point seeing different folks who are representing the majority of the cases. I think it's not useful sort of in that sort of time trajectory to do that. I mean, for instance, I think a lot of the cases that we're seeing nationally as well as locally are in younger people. So that I think is a lot different than what we saw in March and April. So I don't think we have any evidence that the virus is mutating to be weaker. I think that right now we're at a time where a lot of transmission may be starting from gatherings and more among youth. So I think we have to be very cautious about drawing conclusions based on that snapshot.
Great, thank you. And I think I also want to remind everyone this is a webinar that we had much earlier in the year, but our health department calculated what we call the attributable deaths to COVID-19, which may be when a healthcare system is very overwhelmed. There are deaths that are not directly due to COVID-19, but because of the strain on the healthcare system, unwillingness to access healthcare, et cetera. And so I think that might also be a contributor to why we think we're seeing less deaths, though we have seen increased cases. And I also want to remind everyone that, while we have a case count reported from March and April, for a lot of that time, testing was not widespread. And so there's a different way that we're measuring the way that a case is measured is a little bit different now given the increased access. All right. And we also have a comment from our favorite Dr. Blank that treatment has improved since March and April. And then I think there was a question in general about, and maybe Dr. Foote can speak to this, to speak to what the evidence and what we think is happening with reinfection, also resurgence, and what happens when a person tests positive by PCR, gets better, and then tests positive again.
Hi. Well, we are we are now seeing increasingly there have been a few reports now in the literature that have looked at this scenario where you have somebody that tested definitely had a confirmed positive PCR infection with clinical illness, fully recovered, and several months later, more than 90 days out, then develops further another course of illness, and again tests positive for PCR. And what's compelling about this, case reports that are starting to come out, still not a lot, but a few where they've been able to do genetic testing on both the initial and second viral samples from the two infections, and they are looking to be different genetic strains of the virus, so which indicates that these are true reinfections. It seems to be a more mild illness, except for there's been one reported death from a verified reinfection in an older, severely immune-compromised patient. But in general, from what we're seeing, it's still considered to be an infrequent phenomenon. But, as we get further out from the, initial wave of infections, and I think there are many studies that are looking at this ongoing. So I think we'll start to learn more and more information to see, how immunity wanes or leads you to susceptible for repeat infections. Thanks.
All right, and I think it's 2 o'clock, so it's 2:01. So thank you to everyone. And then, Allison, would you like to close us out?
Joining us again today, and our next webinar will be continued on this biweekly schedule, which will be Friday, October 30th at the same time, 1 to 2 p.m. As Dr. Ray indicated, you can find slides and a recording of this webinar on the provider page of our website under the webinar tab. Those should be posted by tomorrow afternoon. And we thank you again for joining us.